Hello and welcome. Thank you for joining us today. My name is Lorna Neeland, and I'm the Director of Engagement at the Swedish Foundation. The Foundation is the fundraising arm of Swedish, the largest nonprofit healthcare system in Washington State based in Seattle. I would like to take the opportunity to thank our donors who are joining us today. Without your support, we can't continue the innovative work we do every day for our patients. This is the third series of education events for women's wellness. We hope you're able to join us last month where we discussed weight, exercise, and menopause. If not, we have provided a link in the chat. You can also access our past webinars at swedishfoundation.org and go to virtual events. We will be recording today's event and will be uploaded to our foundation website in the coming days. We also will be sending each of you a link via email. The Women's Wellness Series promotes our vision for the women's wellness and GYN specialty services. An extension of Swedish, the program will provide every woman coordinated care that meets her unique needs now and in the future with a focus on prevention, menopause, sexual health, and healthy aging. We are excited to announce the opening of the clinic will be this December. We will begin to offer our gynecologic specialty services to address menopausal transitions and sexual health. Our minimally invasive GYN surgery clinic opened last month, and our team of specialists are eager to provide you with referrals and access to services such as cardiology, behavioral health, primary care, and surgical services. We will launch additional services such as wellness and educational programs over time to help address your needs as a woman. Regarding how our time together will proceed, we will be asking questions to the panelists, but this event is also meant to be informative and interactive. So please enter your questions in the Q&A. We will answer your questions throughout the call and at the end. Also, there is an option when entering your questions into the Q&A to mark them anonymous if you prefer. Now, I would like to introduce Dr. Tanja Sorensen, the Executive Medical Director for Women's Services at Swedish, to talk about the vision of this new and exciting program.
Thanks so much, Lorna. And thank you everyone for joining today. Very much appreciate your spending time with us. Swedish aspires to be the primary destination for women's wellness and GYN specialty services. We're focusing on coordinating care, prevention, wellness, and aging. In 2019, we gathered a group of very dynamic women, hopefully many of those on the call today, to hear their concerns and try to answer questions about what they feel their healthcare is providing and actually what's lacking. The themes that we heard were that women would like someone on their healthcare team who's their advocate in seeking answers and helping coordinate their care. They wanted proper information and they wanted a holistic approach. Our program will provide comprehensive care for women at every stage of life. This will provide coordinated care, meeting unique needs, and in future, a focus on prevention now and in the future, with focus on prevention, menopause, sexual health, and healthy aging. We already have a very excellent nationally known GYN oncology group, and you'll hear from Dr. Drescher today. And we've already launched some of our services. We're just now able to, thanks to generous donors, open the clinics that Lorna mentioned on minimally invasive surgery and menopause, as well as urogynecology and sexual health. According to Forbes, women aged 40 to 59 have the highest rate of depression based on age and gender in the US. And women have a 1 in 5 chance compared to a 1 in 11 chance of men to develop cognitive dysfunction. And that is highly correlated with cardiac wellness. So as we move forward, we will be adding brain health for women and cardiac wellness services as well. And so that will be, I just stay tuned that those will be part of our program in the very near future. So as we work to build this, I have to say it's impossible. It would have been impossible to get where we are without community support. And we're very happy to announce a significant gift we've received as seed funding for the program. As innovative programs such as this are really only possible with generous support from the community. We're also grateful for additional gifts of up to $50,000 from a dedicated group of supporters, including members of our Swedish Foundation Board of Governors, who are helping us provide educational outreach events, such as this Women's Wellness series. So today, you're going to be hearing from Dr. Charles Chuck Drescher, Medical Director, Swedish Gynecologic Cancer Research, Dr. Rebecca Dunsmoor-Su, who's our Medical Director for Menopause and Swedish Women's Wellness and GYN Specialty Services, and Dr. Emma Grabinski, who is our System Chief for OBGYN and Perinatology at Swedish OBGYN Specialists. Lorna, after thanking this group of women for joining us, please introduce our speakers.
Thank you, Dr. Sorensen. I would like to welcome Dr. Charles Drescher, Dr. Rebecca Dunsmoor-Su, and Dr. Emma Grabinski. Thank you so much for taking time out of your busy schedule to be with us. So before we begin, I would like to ask each of our experts to tell us about themselves. Would love to hear about your journey, your current practice setting, and why did you choose to focus on women's health? Dr. Drescher, can you start?
Yeah, well, good afternoon. First, I just want to thank the group I'm super excited to be here. And I want to just thank the organizing group for inviting me, and also just want to thank this large audience for their interest in these really important topics. So my name's Chuck Drescher. I'm a gynecological oncologist, and what that means is that I care for women who are either diagnosed with or at risk for gynecological cancers. And in that realm, we focus on 5 disease sites, cancers of the ovary, endometrium, cervix being the most common, but then also cancers of the vulva and vagina. And I think somewhat in line with the overall focus of this whole group is that, in contrast to oncologists at other disease sites, gynecological oncologists actually try to provide comprehensive care. So we manage risk assessment and early detection. We also do surgeries, give chemotherapy, hormonal therapy, and medical management, and participate in surveillance and follow-up of our gynecological cancer patients. So we try to be holistic and integrated, obviously working with all the other support services at Swedish, but it's ideally in the vision sort of one place to go. So, who am I? What do I do? Where do I live? So my practice is in the Gynecologic Oncology Clinic at the Swedish Cancer Institute. I'm one of 6 gynecological oncologists that work there. It's really, I think, a well-kept secret that we're actually the largest gynecological oncology program in the state, and also one of the largest, truthfully, in the country. So our program is in the ranks in terms of volume with the MD Andersons and Sloan Ketterings and Mayo Clinics of the world. We, as I said, provide comprehensive care. We have a large clinical trials platform. We enroll about 80 women a year into either treatment trials or biospecimen collection trials or early detection studies, focusing on diagnostics. How did I get here? So in terms of that, just like all the other panelists, as a gynecological oncologist, we do a residency in OBGYN, but partway through that, I really was sort of struck by the impact of gynecological cancers on women, and it just sort of drew me in, because by and large, these are cancers that tend to not be the fault of the person. There's not a lot of environmental factors, and they tend to strike at difficult transition times in people's lives. And that was moving for me. So to try to have an impact was what motivated me. So I think that answers all of your questions. So I will stop. Thank you. Glad to be here.
Thank you so much. We're happy to have you. Dr. Dunsmoor-Su.
Thank you, Lorna. So I am Rebecca Dunsmoor-Su. I'm the medical director for menopause and for the Women's Wellness and GYN Specialty Services Clinic. My journey to this place is a little circuitous. Obviously, like Dr. Drescher, I started in general OBGYN. And for many years, actually practiced as a generalist OBGYN, doing obstetrics and gynecology. Did all my training on the East Coast and came out to the West Coast to practice at the University of Washington for many years, and then moved over to Swedish in 2013. I always had an interest in reproductive hormones and endocrinology, and really started to build my practice around the transition into menopause in the last 5 to 10 years, because it's an area that I feel like is somewhat underrepresented in gynecology training. And so it's something that I could really learn a lot about and specialize in. I also have a background in epidemiology and biostatistics. So reading the various studies and really delving deep into hormone therapy and understanding the risks and benefits truly to women was key to sort of how I structured my practice. And now I get to do GYN only. I see patients for menopause and vulvar and vaginal disorders, sexual pain, sexual function, hormone therapy when it's appropriate. And I do some GYN surgery in terms of hysteroscopies and laparoscopies and vulvar surgeries. And that's sort of how I got to the place I am. I just love being a part of women's life as they age. I think gynecologists are key in women's care as women age, and I want to continue to be a part of that.
Wonderful. Thank you very much. And Dr. Gravinsky.
Hi, I'm Emma Grabinski. I'm one of the generalist OBGYNs. I work at the Swedish Medical Group, First Hill OBGYN Clinic. I also see patients in Ballad. I'm a full scope generalist, meaning I still deliver babies, I perform surgeries, do preventive screening, see patients in the office. I was really attracted to the specialty just because I think that, unfortunately, there's a lot of things that women suffer with, or people are embarrassed to talk about, such as, pap smears or abnormal paps, or the fact that they're, so very, very common, urinary dysfunction, urinary leakage after having a baby. People are embarrassed about having these conversations, and a lack of education around reproductive health care and around sexual health care. And I just have a big passion for educating women and their families, and educating other healthcare providers, and really empowering women to really understand their own bodies, and be able to make really informed decisions about their care in a non-judgmental setting.
That's great. This is amazing. Thank you so much to each of you again for being here. I feel very lucky to be here with you all. So thank you. And shall we begin? Today we will be discussing gynecologic health and screening. And I would love to start with a poll. Pap smears are not always recommended after age 65. Who does this advice not apply to? Please select what you think. Women with immune suppression, women with recent history of abnormal pap, women who were exposed to DES, and I'll have the physicians talk about that because I can't actually spell that out. Women having unusual bleeding after sex, or all of the above. So again, the question is, pap smears are not always recommended after age 65. Who does this advice not apply to? So once we get the results, we'll put that on the.
I apologize in advance for structuring a double negative question there.
That's okay. All right. So looks like the majority of you, 87% said all of the above. So pap smears are not always recommended after age 65. And who does this advice not apply to? And then everyone thinks all of the above. 9% of you thinks women with recent history of abnormal paps, and then women with immune suppression, and then women who are exposed to DES. So, Dr. Rabinski, can you let us know what group of women should still be getting pap smears?
Yes, I'm very happy that the vast majority of people got that question correctly. I'm glad that message is out there. Basically, pap testing is screening for precancerous changes, and is the recommendations from the various bodies are for women who are at average risk of either precancer or cancer changes of the cervix. And so anybody who's at a higher risk, and that includes people with immune suppression, if you've had a recent abnormal pap or you've been treated for really abnormal paps within the past 20 years, if you have other conditions that put you at higher risk, or you have symptoms such as bleeding, which could indicate a problem, then you really do need to keep being screened to make sure that we're not missing something or that you're not developing abnormal changes.
Great, thank you. Because when we were growing up, and even after children, many of us were told to get pap smears every day. And I know you talked about the different recommendations. I'd like to start with cervical cancer screenings. It seems to be pretty confusing for some people. Dr. Grabinski, when did this recommendation change? And I think you did touch on this about not getting pap smears every year. And then how does HPV testing play into this?
Yeah, I mean, I've been out of residency now for about 10 years, and the guidelines changed while I was in residency, and I think they've changed another 2 or 3 times since I've been out of residency. So, I mean, it's confusing for OBGYNs, let alone, everybody else out there getting pap smears. But basically things have changed as we have more understanding about the causes of precancerous changes of the cervix, and a better understanding of what we can do to prevent it. So, a big thing is vaccination against human papillomavirus, or the HPV virus. High-risk HPV is a virus that attaches itself to the DNA in the cervix and can cause changes which predispose women to precancerous changes of the cervix. And so if you're vaccinated against the high-risk strains, you're much, much less likely to get precancerous changes, and so could potentially space your pap smears out because you're going to test negative for high-risk HPV. One of the big things that we have started to do is co-testing. So we test people not just for PAPS, which looks at the cells on the cervix and if there's any abnormalities or any changes, but we also test people for the presence of high-risk HPV. And if you're negative for high-risk HPV, we know that it takes many, many years for you to be exposed to high-risk HPV, and you really need persistence. So the high-risk HPV needs to be there, causing these abnormal changes to predispose you to cancer. So we know that for women who do not have high-risk HPV, that they're very, very low risk of developing precancer or cancer changes in the near future. And so, there's not one easy answer of how often you need to get a pap smear, because now, which I'm really excited about, we're able to individualize treatment plans for women and really base our recommendations on their history and what's the best for them. And so it may be anywhere from 6 months to 5 years, depending on your history and your other risk factors and your presence of high-risk HPV.
Great, thank you. So, if you've had an abnormal PAP in the past, Dr. Dunsmoor-Su, do we follow, it sounds like Dr. Grabinski addressed this about having it be more individualized. What are your thoughts on that?
It is very individualized, Lorna. And one thing I talk to patients about is oftentimes we think about abnormal PAPs as anything that's come up on the report. So sometimes that abnormality has nothing to do with HPV. Sometimes it's that they saw signs of a yeast infection or some inflammation that really doesn't predispose you to cancer. So you may be actually still at very low risk. So when we're looking at a history of abnormal paps, what we're really looking for is that HPV or HPV related changes. And how long ago were they? And have you, since those changes, cleared your HPV so that we've done several pap smears where we don't see it anymore? And one of the things we know about HPV infections in women is that the majority of women will actually clear them over their lifetime, and they won't go on to cause cancer or changes. And certainly we're seeing that more and more, especially now as our patients have been vaccinated for HPV or aging, we're seeing less and less of those changes, which is a great thing.
Great. And, you know, as you were talking, Dr. Dunsmoor-Su, we had a question come in. I was diagnosed in 2001 with HPV, but my last 2 tests were negative. Should I still get an annual pap smear? I am 69 years old.
So we typically, that's a little bit of an individualized medical plan, which we can't do via webinar. But in general, what I tell my patients is I like to see 3 negatives before we start spacing or stopping screening. So I would start there and then talk to your doctor about what their plan for you might be. Because I don't know your whole history, obviously, so I can't make a real medical plan.
Absolutely. Absolutely. I appreciate that. Thank you. So Dr. Drescher, as an oncologist, does it concern you that we don't screen as often as what was recommended in the past? Do you think that not screening as often leads to more cancer? And are there also cervical cancers that are not HPV related that we are perhaps missing screenings for?
Yeah, great questions. I might take them, I guess, a little bit in reverse order, if that's okay.
Yeah.
What I would say is the HPV or the human papillomavirus, there are multiple different viruses, but in the family, it really is the causative agent in the vast majority of cervical cancer. So 99+% of invasive cancers of the cervix are associated with HPV. Now, there are a few rare subtypes that are less likely or potentially not associated with HPV infection, but those are not the targets of screening and not really what we're trying to detect with our screening programs. With respect to the kind of frequency, the interval of screening, what I would say, I just want to clarify screening versus follow-up of abnormal pap smears, because that's, you know, really quite a different thing. And as you heard, the follow-up to someone who has an abnormal pap, whether it's HPV only or HPV with some type of cytological abnormality, really nowadays is risk-based and highly individualized, which is really a good thing, but it is complicated for the patient to understand. And when you talk to your friends about, you know, what's going on, it really, there'll be a lot of variability, but it's really all individualized and risk-based. When we think about screening, I'm thinking more about primary screening and focusing really on the sort of average risk group, leaving out the high risk groups, which are, you know, immunocompromised and DES exposed, as you mentioned, and symptomatic patients. So these are kind of the asymptomatic average risk group, which the vast majority of women fall into. And so basically within that kind of group, there are kind of 2 strategies to screening. One is HPV based, so you can do primary screening using just testing for the presence of human papillomavirus. Or you could do cytologic screening, which is kind of more in line, kind of the traditional approach, where you basically scrape cells from the surface of the cervix, and then they are put on the slide and subsequently reviewed to try to identify a range of cytological abnormalities, meaning the cells look not normal in one way or another, potentially along the spectrum towards cancer, to co-testing, where you do both together. And the intervals between those different strategies vary, but I think the take-home message, really critically important to understand, is no matter what strategy you're following, the incidence rates and the mortality incidence rates, the probability of getting invasive cancer of the cervix and the death rates for anyone who's following any of the recommended screening strategies is like super low. So basically, if you kind of do what's recommended and have follow-up, and even though it's kind of confusing, and I know we all want to understand aspects of our care and it's critically important, but if you follow the recommended guidelines, the outcome is going to be excellent. Now, the differences in the interval really vary depending upon what you're using for your primary screen. So HPV testing is exquisitely sensitive for detecting papillomavirus, the causative agent for cervical cancer. It's also likely more sensitive than just regular cytology for detecting something called high-grade precancer, which is sort of the known precursor lesion for invasive cancer. That's like the step before and the thing that, what we're really trying to detect and treat. There's lots of other abnormalities that show up in pap smear screening. They're not as relevant or as critical. We spend a lot of energy and effort, managing them, but they're really not the target for screening programs. They're just kind of the noise in the whole system. But HPV testing is exquisitely sensitive for detection of HPV, the causative agent. It's more sensitive likely than cytology for detecting the real precursor lesions. And there's really good data, not randomized, but observational, large numbers of women being followed, that with a 5-year, if you use HPV either as primary testing or co-testing, 5-year screening intervals are effective and safe, and the incidence and mortality rates are extremely low. Now with cytologic screening, if you're just looking at the cells on the slide, trying to identify precursors or cancers, that's not quite as sensitive, it seems, for the high-grade precancers. And there's also more kind of sampling issues with that. So when you're doing a cytology-based screening, the recommendations are every 3 years. So the variation is primarily around what you're using for your screen, but in either circumstance, as long as you follow the recommendations, the outcomes are very good. The other point I want to make is it's like critically important to think of screening not as necessarily a test, but as a screening program, so that participation is over time. And particularly in cytology-based screenings where the sampling is an issue, having the opportunity to repetitively sample is like critically important. So the current thinking about the transitions, and there's a lot of variation around this, but the transit time from encountering an HPV infection to developing a precursor, a high-grade precursor, that high-grade precancer, to developing invasive cancer, in almost all cases spans decades. So whether you're getting a 5-year screening interval or a 3-year screening interval, you're having multiple opportunities to sort of sample and intervene and detect. So again, just going back to the bottom line, I know there's likely a lot of confusion, but the current strategies work. You just need to adhere to them.
Thank you. Thank you for going through that. Along the same lines regarding pelvic exams, I want to talk about pelvic exams, and I also want to talk about a cancer that really worries women, and that's ovarian cancer. And I know that we do have some questions in the chat, and we will definitely get to them, but I think it would be good to know. I'm thinking, Dr. Grabinski, so not all doctors recommend a pelvic exam after a certain age. Do you think that they continue to be useful? And, if we can start talking about ovarian cancer, do they help us pick up ovarian cancer?
I'm not sure that the pelvic exams or routine pelvic exams help to pick up ovarian cancer. But I think that there's a couple of different things to think about where pelvic exams are concerned. So the first is that if we're not experienced at doing pelvic exams and feeling a range of what's normal, then as practitioners, we're not going to be able to discover what's abnormal. And so it's really important that we, do experience normal pelvic exams as providers so that we can teach ourselves what feels abnormal and raise it with patients. I think the other thing is that the pelvic exam has a role in terms of, this is Dr. Dunsmoor-Su's expertise, but like seeing if there's any changes in the skin. Do you have like a skin disorder that we can help treat? Do you have any prolapse? Women may not realize that some of the symptoms, such as low back pain that they've been having, or urinary leakage, is associated with a prolapse. And these are all things that we can, help to treat. And so I think that it's important screening tool. There's also rarer, but unfortunately less well-known cancers of the skin on the outside of the vaginal area, so on the vulva, which, if nobody's looking for it, you're not going to find it. And then the other thing is that I think it gives us a unique ability to be able to teach people about, their anatomy, see, are they having, pain with or discomfort with intercourse, which they're very unlikely to volunteer until we ask them about it when we notice that they have vaginal dryness after menopause. But also, giving them education about what signs and symptoms to look out for where things like ovarian cancer are concerned.
Thank you. Dr. Dunsmoor-Su, do you have anything to add? You'd like to add to this?
I appreciate that Dr. Grabinski brought up skin disorders and vaginal disorders. These can occur to a lot of women, especially as they transition into menopause, and it is something we don't ask about and we don't talk about. And so in doing a pelvic exam, we're really able to look at those things and say, hey, is this a lack of estrogen that we can fix easily with estrogen? Or is this a more concerning skin disorder that maybe needs different treatment? And so that's really a big part of the pelvic exam.
Great, thank you. I want to address these questions. And so I'm going to ask Dr. Drescher, ovarian cancer has, ever since I've been involved with ovarian cancer, it's sometimes called the silent killer. Is this still true and why?
Yeah, thank you for bringing this topic up. It's cancer that's, really important to me, and it's been a focus of my research career for quite a long time. So I guess, ovarian cancer is clearly a very serious disease. I don't want to minimize that in any way, but I think I would push back a little bit on this characterization of the silent killer. I think that's very much a holdover from years past. So let me just speak to the issue of silent. So there's, a lot of research now to suggest that many women who have been diagnosed with ovary cancer have symptoms prior to their diagnosis that precede the diagnosis by months and occasionally years. The big challenge has been and remains that those symptoms are vague and nonspecific, and frequently can be attributable to a lot of other much more common diseases. So that the typical symptoms you would hear are bloating and fullness and what we call early satiety, where patients feel full when they eat early, fatigue, urinary symptoms. So these are kind of often attributable when patients complain of them and they're vague. They're either discounted or attributable to other diseases, and docs and patients take off on a number of different pathways unrelated to the ovaries to try to resolve them. I think what has happened, there's been a lot of education in primary care as well as patients themselves, and I think an important first step that's been implemented with increasing frequency is, when someone presents with these vague symptoms, to consider a pelvic ultrasound very early on, and sometimes even a CA-125 blood test. So the other comment I would make about symptoms, it's not really just the presence and absence of symptoms, it's also very much the temporal characteristics. Is this something that's increasing in frequency or severity? So, we all have these vague abdominal symptoms that kind of come and go all the time. So, I'm sure we're all kind of moving around in our chair. But in any case, it's not just did I have it today and not next week. It's much more temporal characteristics. So I would push back a little bit on the silent. And then on the killer side of it, so as I said, it's a serious disease, and outcomes for women who are diagnosed with ovarian cancer, unfortunately, overall remain suboptimal. But I think the reality is far from the kind of general perception in that, so typically young women or women who are diagnosed with early stage ovarian cancer have typically a very high probability of being cured. And patients who are diagnosed with advanced stage ovary cancer, the outcomes I've been doing this for a few decades, and I can tell you the data clearly show outcomes are substantially improved. So survival rates are extended meaningfully. Something that I like to quote frequently is that the number of women who live with a diagnosis of advanced stage ovary cancer beyond a decade has tripled within the last 10 years.
Wow.
And truthfully, with the number of treatments that are currently available, I think the last time I looked at, if you look at the NCCN guidelines, there are like 14 approved therapies for ovary cancer, but there's a lot of treatments, a lot of opportunity to control disease. Now with the understanding molecular aspects of ovary cancer and the identification of new classes of drugs, in particular these PARP inhibitors, there's actually real strong evidence that even patients who are diagnosed, a subset of patients who are diagnosed with advanced stage high-grade serous cancer, which traditionally you think of as being the most aggressive type, can be cured. There's definitely progress. So as I said, I don't discount this in any way, but I think silent killer is potentially the wrong picture in my mind.
Well, this is wonderful news. And I think, the research that you're doing, Dr. Drescher, is obviously helping towards all of this for our patients. If you guys are okay with it, I'm just going to address some of the questions that have been coming in. They've been coming in since we started talking about ovarian cancer, and know that if you've put it in a question, we will get to it today. And if for some reason we don't during this time, we will follow up with you individually. So one of the questions is, and you've addressed this as well, I am terrified of ovarian cancer, having witnessed 2 loved ones, friends being diagnosed, treated to a point of quality to a point of life quality ending, then ultimately passing away. What hope is on the horizon to catch this nasty thing earlier, to create greater chance of treating earlier?
I guess I'll take that. So that's obviously a great question, and early detection and prevention is very much an area of interest for me. So just to be clear, I mean, the current state of ovarian cancer early detection is, unfortunately, we're not there yet. There's sort of 2 clinically available tests. One's an ultrasound and the other's a CA-125 blood test. And unfortunately, their performance isn't sufficient to be able to be used as a screening test in the kind of general population. It's not recommended and truthfully shouldn't be done. There may be a role for those tests in a well-designed program for women who are at high risk, high genetic risk in particular, and there could be a role prior to like risk reduction surgery. So in terms of where are we, what's the progress, what's the hope? So more and more, we're understanding the natural history of ovarian cancer. So anytime you design a screening program, you really have to know what it is you're trying to detect. And until very recently, that wasn't possible. And perhaps one of the most interesting shifts in the last decade is the understanding that most of what we consider to be this high-grade serous cancer of the ovary actually arises in the fallopian tube. And so that's sort of changed the focus away from the ovary to looking at the fallopian tube. We also have a reasonable understanding of sort of what's the target? You know, how small of it do we have to, when do we have to get in there to prevent cancer? And truthfully, this is what we learned with cervical cancer with pap smears. I mean, we didn't know anything about the preclinical history of cervical cancer until we're with pap smears. And I feel like we're on that analogous path in ovary cancer now. But the bottom line for ovary cancer is, you know, you probably have to find it when it's less than 1 centimeter in size and more likely in a range of about 5 millimeters in order to be able to like intervene and have a meaningful impact. And so the question is, how do you go about that? And there are a number of ways to do that. One very promising approach is to capitalize on the idea of your immune system as essentially an amplifier of a signal. So when you get a viral infection, you know, your body, even when it's just a small inoculation, the natural tendency of your immune system is to respond to that. You get these huge immunoglobulin antibody responses, you get T cell responses in your blood, and these are all detectable. You're not actually detecting the virus per se, you're detecting your body's reaction to that. So I'm trying to capitalize on that because tumors are essentially abnormal to your body, to try to capitalize on an immunological response to a super small tumor is sort of one strategy that seems to be holding promise. The other is options for trying to look for a signal in something other than blood, because blood is a mixture of everything in your body, and to try to get more proximate to where the source is. And that can be done either with, there are tools now to essentially get a sample from lavaging the uterus and actually accessing the fallopian tube. So basically getting closer to the source of where cancer is and better imaging. There's a lot of work going on. There was a recent study that was just done that showed that you can shift the stage of diagnosis. We can actually move the ovarian cancer from a more advanced stage to earlier stage, but not quite good enough to save more lives. So my message here is, you know, we're not there yet, but there is a lot going on that I think is very optimistic. And I honestly just touched on it. But I'm happy to talk to anyone else offline about it.
Dr. Drescher, thank you. This is a wealth of information that we really appreciate. So thank you. So I'm going to talk or address 2 more questions, and Dr. Grabinski and Dunsmoor-Su, I'm sure the both of you can do this, but there's 2 questions. The first one is, what is recommended for those who have had a full hysterectomy, including tubes and ovaries? I'm 70. My mother died of ovarian cancer in 1992, and I haven't had a pap test since. So that's one question. And then the other question is, what is DES that has been referenced a few times? Because I couldn't pronounce it. So so between the both of you, who'd like to take this on?
Doesn't Emma start, and then I can chime in at the end.
Sure. So I think, you know, for the person who's asking about, you know, gynecological screenings, I mean, I think it really depends, again, what you consider gynecological screening. So as a gynecologist, you know, I view my job to take care of the whole person. That's one of the reasons why I came into this specialty. So, you know, kind of talking about pap screening, talking about colorectal screening, talking about breast cancer screening. These are all things that I do with my patients in a gynecological setting. After having a hysterectomy with tubes and ovaries removed, if there's no history of precancer changes on the cervix, then you're extremely unlikely to have cancer of the cervix or cancer of the vagina as a result of precancer changes on the cervix. And very, very unlikely to develop ovarian cancer when you've had your tubes and ovaries removed. I think that the important thing to realize is that the pap test itself, I think women view the pap test as being the pelvic exam, whereas actually the pap test is only when we use the brush to take a sample from the cervix cells. And that only tests for cervix cancer. It doesn't test for ovarian cancer. It doesn't test for cancer of the uterus or anything else. And so after having a hysterectomy, if you've never had any abnormal paps or, you know, had mild abnormalities many, many decades ago, there's really no need to get a pap test. And in fact, I would discourage it, because some of the changes that can happen after menopause can cause some false positives, and that can actually lead to a lot of stress. I think it's absolutely still important to see either a primary care specialist or a gynecologist. You know, I'm absolutely not an expert in high blood pressure or you know, heart disease or thyroid or anything like that, which is important to see a primary care specialist. But you know, as I said before, you know, seeing a gynecologist can absolutely help with quality of life issues related to menopause, with related to urinary dysfunction, relating to, you know, sexual dysfunction that can happen as women age. And that's, you know, something that we're very happy to help women with. And then also, again, you know, women can have a lot of questions about what their vulva looks like, and if things are normal, and counseling regarding what's normal, what's abnormal, and when you should seek care is, I think, something that's important to still do periodically. So maybe not every year, but I think, you know, periodically it's a good idea to check in with a women's health specialist.
I'll jump in and take the DES question, because I know it has, I've seen it in the chat as well. DES is the initials for a compound called diethylstilbestrol. And this was a medication that was given to pregnant women, really starting as early as in the 40s and 50s, but right through to 1972. And in 1972, it was taken from the market and stopped being given because we realized that, or I say we, I wasn't practicing medicine in 1972. It was realized that that compound, when given to moms who are pregnant, caused vaginal and cervical changes in daughters and fertility issues in daughters. And the reason we bring it up is that women who are adults now, who were exposed when they were in their mother's bodies in utero, can have changes of the upper vagina and cervix that can be precancerous, that we can detect sort of throughout their lives, but they can also be at higher risk for something called clear cell adenocarcinoma of the cervix or vagina. And this doesn't seem to be related to HPV. So HPV testing doesn't rule it out. It also doesn't, we don't know the full natural history of it, because obviously these are women we've been following as they age, but we don't know that there's an end date to when that risk ends. It's not like, you know, if you get to 60, you're no longer at risk. You need to continue screening sort of throughout your life, because we just don't know when that risk will end. It's a very rare cancer, but it does still appear. You should know if you were exposed in utero. Your mother should have been told, and you should have been told. So you will know if you need to have that continued screening.
Thank you. You know, speaking of family history, there are two questions in here. I'm just going to read the questions and then we can go from there. And if a woman has had a hysterectomy, including cervix removal, and forgive me, oohortomy, I don't know if I said that right. What, if any, gynecology screenings are in order going forward? So that's the first question. And then the next question was, am I at higher risk of developing uterine cancer if my mother was diagnosed with it? If so, what would regular screening help? And then the next question is, it's very similar, but what screening is recommended for women with a family history of ovarian cancer? So I know that I just said 3 questions, but it's really about family. I think the knitting together is the family history.
I'm going to start, but then I'm going to toss it to Dr. Drescher for more specific information. I think family history is sort of a difficult thing to quantify. There's a difference between having one relative in your distant family who has a cancer versus having multiple relatives or very near relatives. So family history in and of itself doesn't necessarily give us enough information to say exactly how much at risk you are, although it's something we do take into account. And certainly there are genetic predispositions to particular cancers, including uterine cancer or ovarian cancer. And so certainly if you have a strong family history, we often recommend genetic screening so that we can better understand your risk. That genetic screening can be more useful if we actually know about the family member who had cancer and their genetic status. Because if they had, say, ovarian cancer, but were negative for all the genetic tests, it's not as helpful to know if you're negative. In terms of the uterine cancer specifically, I talk with my patients about the fact that we do have good studies that show us that routine screening for uterine lining thickness is not that helpful. That does not apply to people who have genetic predisposition for uterine cancer. They're a different population. But in the general population, even if you have a family member who's had uterine cancer, when we just look at the lining, if you're not having any symptoms, we do a lot of maybe unnecessary procedures. Whereas if you have any bleeding after menopause, so menopause being defined as 12 months without a period, if you see bleeding after that time, you do need to be evaluated, because usually the first sign of uterine cancer when it's very early is bleeding, and bleeding from the uterus. So whenever you have bleeding in menopause, it's important to come see a gynecologist for evaluation. And that evaluation usually involves some kind of biopsy and maybe a scan like an ultrasound. And when I say some kind of biopsy, sometimes that biopsy is done in the office and sometimes that biopsy is done in the OR. It sort of depends on what we see on your ultrasound. And then Dr. Drescher, do you want to talk a little bit more about family history of ovarian cancer and screening regimens?
Yes, definitely do that. And then let's also consider time. I want to make sure that we're at 12:52, and now I'm wishing this was a 2-hour webinar, because I feel like we have just touched the surface of this. So Dr. Drescher, I didn't mean to cut you off, but
Yeah, no, I just wanted to, I think there were 3 questions. The first was about cancer screening in patients who had hysterectomy and removal of tubes and ovaries. And I think that was discussed earlier, and there's definitely a role. And, there was a conversation about skin changes, but there are skin changes of the vulva, and there are a lot of sort of early skin changes that could lead to a rare problem, vulvar precancer and even vulvar cancer. So these are the types of things that can be detected. And I think the other thing that maybe wasn't mentioned is the opportunity to do a digital rectal exam, which is, part of screening for anal cancer and rectal cancer. So, I mean, there's definitely value from a cancer screening as well as other health issues from a gynecological exam post hysterectomy and tubes and ovaries. So the endometrial cancer, so most of the heritable risk, the genetic heritable risk for endometrial cancer comes through a syndrome called Lynch syndrome. And this is basically due to defects, mutations, and a family of genes that are associated with process called DNA repair. So basically genes that help kind of monitor the integrity and health of your own DNA. So Lynch syndrome is typically associated with a family history of colon cancer. That's how it's generally detected by family history. But patients who have Lynch syndrome are at elevated risk for uterine cancer. And sometimes uterine cancer is the first, not infrequently, presenting indication of Lynch syndrome in a family. So the current recommendation for anyone who's been diagnosed with endometrial cancer is to have screening for Lynch syndrome. And that's actually not done on the patient, it's done on their tumor. So for patients who have a family history of endometrial cancer, the first place to turn would be to see whether or not their family member had their tumor screened for evidence of Lynch syndrome. Absent that, then you have to then look at the bigger family history, and that's when, as Dr. Dunsmoor-Su mentioned, it becomes a bit more complex. With respect to ovary cancer and heritable risk in family history, so most of the family history risk with ovary cancer can be broken down into whether you have a mutation and whether your family has a mutation in an ovarian cancer susceptibility gene. And those are typically what we call BRCA1 and BRCA2, but there are others. And as was mentioned, the best way to check for that is to test the affected patient. So the person who actually has cancer. Now that's not always possible, in which case then if you have concerns and there is a family history of ovary cancer, you can present for, you're appropriate to have genetic counseling, and if after that have genetic testing to try to look for a mutation. If that mutational testing is negative, then your own risk becomes really quite low, as long as your family history is not extensive. So my message about this is if there's a family history of ovary cancer, it's ideal if the affected person gets tested. And everyone who is diagnosed with ovarian cancer, the current recommendation is that they should have genetic testing. If that's not possible or feasible, then if you have a first or secondary affected family member and you don't have cancer yourself, you're still an appropriate person to consider genetic testing. And if you have genetic testing and that testing is negative, then your worry and your actual risk goes down quite a lot. So we are now moving more and more in an area for ovary cancer of molecular based risk assessment through molecular testing. So the family history part of it, while it's important to identify people, it's more like a signal. It's more like a warning sign, but not a predictor.
Thank you. And Dr. Drescher, I think that is your concluding thought, and that's great. So thank you very much. Dr. Grabinski and Dr. Dunsmoor-Su, any concluding thoughts? What would you like? We're running out of time. If you guys are okay to stay a little bit longer, we can go just after 1, but if you need to hop off, please do. But there's any concluding thoughts before we all say goodbye in under 30 seconds?
I would say that our concluding thoughts are the fact that we are here to serve you, and we want to partner with you to make sure that you have the most optimal health outcomes possible. And so no question is too embarrassing, no question is too taboo, no concern is off limits. I tell people all the time that if they can tell me something that shocks me after 10 years in practice, then I will give them a prize. So please, anything, any concerns that you have, bring it up with your women's health provider, because that's what we're here for.
And I would echo Emma's sentiments that we want to hear what you're suffering from. Even if we don't have an easy solution, we're here to hear it from you and help you to work towards a better quality of life. But that, don't ignore your gynecologic health as you age. Just because you're done having babies doesn't mean those organs don't still have a role and can't still have issues or problems. And we're here to hear about them and help you to solve those problems. And I'm sorry I can't stay longer, but I have to actually go to the operating room to solve some of those problems.
Well, thank you to each of our panelists. I really appreciate it. And thank you to everybody tuning in today. And also, if you're watching this after the actual video day, we have a brief survey that will pop up after we end. And I just want to thank the donors who are here with us today as well. We can't do this without you. And Swedish is here to help women, just like each and every one of you. And as everyone said, we're ready to do so. And if there are questions, feel free to see us. I know that we will be following up with you with the video and some additional information. And so just want to say thank you and wishing you all a great rest of your day.